Well, welcome and thank you so much for agreeing to do this interview today. Do you want to introduce yourself to my followers?
Yep, so I'm Karren Dickson. I'm a ADHD clinical nurse specialist, community CAMS. You're just taking up the post of
Great.
that.
Great. And what does ADHD mean for those of us that don't work in?
So, attention deficit hyperactivity disorder or hyperkinetic disorder.
So you could tell us a bit more about that later. And you say you work in the community, and is it with adolescents or young people?
Yeah.
So up to 18-year-olds. Oh my
Yeah.
God.
So normally from 6 to 18. So we wouldn't diagnose somebody with ADHD really under 6 years old.
Just a bit about how you became a nurse and a bit about your career progression, because I think I've known you for many, many years and you've had many really interesting roles.
Well, my biology. Well, actually, my biology teacher used to tell me that I should be a nurse because I'm good with people, and then I was going to do immunology and other bits and bobs, and then I didn't apply in time, so I went through clearing, and they actually had nursing spaces left. So it's a bit accidental. And they only had child mental health places left. And initially, I was going to join to do children's nursing, but because they only had mental health places left, and back then it was Project 2000, so you had 18 months where you learn everything, and then you could specialize in another 18. So they said, just join in mental health and then change after the 18 months. But I didn't change in the end. I just stayed where I was.
Is it because you loved it so much?
Yes. And so I qualified in 2002. I was a charge nurse and then a deputy and a ward manager on inpatient wards, adults. And then I became a ward manager for an adolescent unit, inpatient adolescent unit, back in 2010. And then I had a couple of years while I was the advanced clinical nurse practitioner for that ward as well. So sort of doing admissions and discharge, clerking in, physical obs, and sort of leading on physical healthcare, doing nurse prescribing, doing phlebotomy, and sort of doing a bit more in-depth physical health assessments. And then after that, I set up the Lewisham CAMS crisis team for a couple of years, and then on to become clinical manager for CAMS Tier 3 initially, and then various other parts. So, and then specialist teams when I came back from mat leave. And then I left the NHS for a little bit, and now I'm back.
Yeah. It's like such a fantastic career that you've had. I didn't tell you about this, but I found, do you remember this?
Yeah.
Magnet Spotlight. And guess who is in it?
Yeah.
There's your article about being a nurse practitioner. I was just reading through it, and I will get you a copy. But I was just thinking, initially you wanted to go into work with young people when you started your training, and it seems like a 360 that you ended up there, but it's not an easy transition, I think, to go from adults into CAMS. Would you say that?
Yeah, definitely not easy. I think it's easier to go from adult inpatient to CAMS inpatient rather than community. I think we are, well, the way I saw it is, I suppose when you're adults, the focus is very much on medicating somebody. Whereas I think with CAMS, we have a more therapeutic approach. And also then you've also consent and capacity comes into it, because obviously a lot of them will be under 16, and therefore sometimes there's conflicts about what parents want and what the child wants. This thing that the CAMS, you put up with more in CAMS than you would do in adults. But I suppose that is true to an extent, because young people are still learning, aren't they? Whereas you'd expect different from someone who's lived the adult life. So yeah, it is difficult. And then the transition from even sort of into community CAMS alone, and the way that the services commissioned in CAMS are completely different to how it's commissioned in adults. It does seem like they've got more services that you can refer people onto than CAMS itself, certainly in the community. Because sometimes what's provided in one borough isn't provided in another borough, which can make it really, really sort of difficult when you're trying to discharge people.
I know, having done my stint in CAMS, that it is totally different, as you say, in adults. And my view of CAMS is we had lots of resources, especially on a ward where you had like a real big MDT, psychologist, music therapy, you know, and the inpatient wards in adults is a bit different.
Yeah.
So there's something about the parity around that, and definitely in terms of, I guess, how services are paid for is different in different boroughs. And you've obviously now worked in 2 different trusts, so can make that comparison across.
Yes, one trust I think seems to have more money than the other trust.
We won't call names. I don't want us to be sued.
But I think also it's also, so the current trust that I'm in, I don't think we ourselves put ourselves out there enough in terms of groundbreaking research and sort of quality improvement stuff. I think we do internally are really good, but externally we're not very good at sort of selling the services that we do have that, say, the other trust that I previously worked doesn't have. So there are, but I think we're just not very, I suppose, good at doing that. We're merged, so sometimes we fall under the umbrella of the old trust that I work with, which can then, so sometimes there's always conflict about, because I've worked in both.
Yeah,
I don't feel that one is better than the other. I think each trust have different things that they can bring, but so it's an
interesting position to be in.
Yes.
So in terms of all the, because you've had an amazing career, and you know, having known you before, you're always one of those up and coming nurses who are going to do great things. And for people listening, it's how do you get into these different roles that you've done? What do you think helped you to do that?
I think I was just a good nurse, not in a egotistical way. I think being empathetic to the people that you look after has helped. And I think getting a good understanding of what people's journeys are as they go through the NHS has helped, because it kind of paves the way on what changes that you can make either to your practice or to sort of services. And then it's always spurred me up. So every time I've gone for this more higher, a senior position, I always did it because I wanted to be able to make a change, to make things better for the people that we look after. So I think that's what's helped progression, being more in touch with the people that we look after. And I think for me, I've always struggled. Sometimes I've wanted to be managerial, and then I've sort of had enough of it and felt like I needed to go back to being clinical and have more contact with service users. And then I think, oh no, I can be managerial again, because then I miss all the pressure that comes with managerial and being able to affect change in a different way. So I've flown in between a few times clinical and managerial posts.
Training that you did to become a clinician that could discharge people doing the nursing practitioner role, do you think that's helped as well in terms of being able to manage your managerial and clinical roles?
Yes, I think definitely, because it's a different thing. So in effect, the doctors would see me as I suppose a junior doctor, though that was never my aim. My aim was always to be a senior nurse. So sometimes that I would get swallowed up with more doctor tasks, but it did help because I was able to do things like chair CPAs and ward rounds, and have a bit more experience in sort of clinical decision making and risk taking, which I think does inform how I may deal with a complaint managerially, or where I think the resources are best sort of spread across in a managerial role, and I think clinical role, it's helped because I think I can think a bit more outside the box. I'm not just thinking sort of necessarily as a nurse, I'm also thinking as an advanced nurse practitioner, but I've also had the experience of working alongside some really, really good doctors and learning from them as well. So yeah, I think it's helped in all fronts.
Cool, great. And in terms of role, just tell us a bit more about what that entails and how it benefits not only patients but their families.
So ADHD Clinical Nurse Specialist. So, but it's more assessing ADHD and their severity of the symptoms. So I wouldn't necessarily diagnose ADHD. So I would already have somebody who's been diagnosed, and we would assess their symptoms and severity and see whether, if they wanted to trial medication, then we could do that. And so I can, I'm still waiting to be signed off, but I can prescribe in that area once my DOPS, my practical forms, are signed off. But also, it's not necessarily just about the pharmacology of it. It's also psychoeducation, and a lot of parents also, it's educating parents and young people about sort of the non-pharmacological stuff, things that they could do to help manage ADHD symptoms, and also things that, because a lot of the times, really, where it impacts on their lives is that when they're at school and having to learn and sit exams and sit still and focus. So it's trying to help them and help schools sort of put strategies in place as well. So I'll do liaison with schools and social care and parents as well. So it's not just purely prescribing. Obviously, the other element of that is the physical health aspect of it, because the ADHD medication is a stimulant, so it can affect your heart, your blood pressure. So it's sort of monitoring physical health if they do start medication as well.
It's exciting. What are some of the challenges in your role?
Challenges in my role, I suppose the long waiting list for an assessment for ADHD, and then the wait list to get from ADHD to then have a review about whether they want medication. So the long waiting list before they get to me, and in between that there isn't much psychoeducation. So they're diagnosed, and then it's like, well, you can these are services that you can go to, or you can do medication. If it's medication, this is what you wait for. So I think there's a lack of psychoeducation. So, and sometimes by the time they get to me, they've been coping for so long that they're so frustrated that sometimes all they want is medication. Because maybe you have families where the child has been, since the age of 6, has been, or younger, has had ADHD, and they don't get diagnosed until late. So that's difficult. Sometimes schools, in terms of perception of people with ADHD, as in they're the naughty or the teenage behaviour or the attention-seeking behaviour, when actually it isn't. It's more the fact that they can't physically sit still, or they can't physically focus, or that they can't control their impulses. So that would be sort of the long waiting list getting to me is a challenge. Sometimes it's having discussions with parents, because sometimes also if they're very young, we don't necessarily always recommend ADHD medication, because you can be immune to it eventually. So your body just stops responding to it, and you don't want to start increasing the dose higher and higher. So sometimes when they're very set on wanting medication, and it may not necessarily be the first thing that you would recommend, and trying to kind of, because the NICE guidelines is that they should really do sort of psychoeducation and do parenting groups and sort of all these other things before the medication. But a lot of the times they're not really given that information properly when they're diagnosed. So then they've just been left waiting, but haven't been able to try anything. So by the time they get to you, it's very then difficult to say, well, actually, these are the guidelines. Another challenge, I suppose, in the borough, in the borough that I'm currently in, there are no adult ADHD services. So when someone's turning 18, where do they go? And I think a lot of people, and especially parents, struggle with, well, they just go to the GP and that's it, because the GP aren't ADHD experts, but we do shared care with the GP. So we wouldn't necessarily, once we stabilise someone on medication, we would do shared care with the GP, and the GP would do all of the medication reviews, and we would then do all the prescriptions. Then we would meet them in a year. So I think some of them struggle. And I had a parent the other day who was sort of saying, well, if I'd have turned up in a different A&E, then I would have been referred to this. So the other trust that used to work for our ADHD team, so I would have been referred there, and that it's trying to get them to answer, well, actually no, because your GP's in this borough, so you still wouldn't have had access. So, and even then, to get adult specialist ADHD, it requires a lot to do the referral. So it's, it depends on the funding and everything else. So it's not as easy as just referring someone to another trust or another borough to have ADHD treatment.
Did you have to do any specialist training to
So prescribing, so I would have had to know about ADHD medication. But when I was lucky enough, when I was in Lewisham CAMS crisis team, I worked alongside, so our consultant was also the consultant for the neurodevelopmental team, and was the lead for the ADHD clinic. So I spent a lot of time with him learning about ADHD medication, along with our ADHD nurse there. So that's helped. Also, I suppose, even though I don't diagnose, when I did my advanced nurse practitioner training, I also did some training on diagnosing things. So with the kiddie SADs, so being able to diagnose certain mental health symptoms. So that's been helpful as well, because sometimes it's been helpful to pick up whether there may be symptoms that may have been missed or underlying. Could somebody be bipolar instead of ADHD, and those kind of things? So it's quite handy to have that as well.
Great. You did mention at the start that you left the NHS for a little bit. I'm just a bit curious about what you did during that time, and coming back, did you find it easy to get back in?
Well, I was on mat leave for a little bit, but before I was on mat leave, I actually just went into property management, so working for an estate agent, JT Clark London.
I could put the link up.
Working for them for a little bit, and then I was on maternity leave, and then went back to working with them, and then recently did some bank shifts at Sutton Spa to do sort of single point of access assessments for young people, and then this role here. I think it was fairly easy to go back into the role because I think it's my expertise. It's something that I've done for so long, so it wasn't as if I think I hadn't been out long enough, and also a lot of my friends work within the NHS, so it wasn't like I was ever really away from knowing about what the current developments are. So every time we'd meet up with people, including yourself, I'd hear about it. So I was never really far away from it. So it didn't feel like I'd been away. I think I was away for maybe 2 years, or almost 2 years, but it didn't feel like it at all.
So that meant you kept your registration up going as well. Yes. So that's really handy for people listening to know that, if you want to take a break, it's fine to take a break, but ensure you keep in contact those networks that you have, so that you have your ear to the ground, and then you can, come back in. Just thinking about any advice you would give to people that want to progress up the career ladder.
Don't be in a rush. I progressed quite slowly but quickly, if that makes sense. Every couple of years I'd progress onto something else, but that gave me a good solid 2 years to learn and to improve and to enhance my skills. Whereas I find these days, so years and years ago, when we used to be grades rather than bands, you were able to have your nurse, so your staff nurse, which is when you start, and then you had senior nurse, then you had charge nurse, then you had deputy, and then when we moved to bandings, the E and F, they all merged, so it was a 5 and a 6, and I find that actually a lot of people that come out of nursing at the moment it's like they're in a hurry to get to a band 6. But I don't think a band 6 means that you should be able to take charge of a ward, manage a crisis without having to call the on-call manager at night, enhanced risk assessment skills. And I don't think 6 months is long enough to do that, based on my experience anyway. I think if you're, some people can do it, but a majority of it, but you have to be really exceptional in terms of how you pick up on things and how your strategic thinking, that's already, that must be already embedded in you. But I think in general, I think before you start being a charge nurse or a clinical, what do we call them now? Oh God.
Yeah, it's charge nurses for inpatient.
Yeah, it is. It's gone back to charge
or
nurses.
if you go into the community, it'll be a community psychiatric nurse.
Yeah.
I'm only speaking about mental health because that's what I know. But for adults, it might be something general. Acute services might be something else, but it's still the same banding. So there's something about not doing it too quickly, taking some time to get some experience.
Yeah. And to learn, because
you
yourself know that you make mistakes when you're learning things. Even at the senior level, there are things that you don't necessarily know so much of that you still need to learn. So I think it's being aware of your limitations, rather than rushing ahead first, because it is a serious career and we do get a pin that can be taken away from us, and we do have a governing body that can determine whether we're fit to practice or not. And I think if you haven't, you can be put in such tricky situations where somebody's safety is at risk, and it may be because due to a decision that you've made. But if you've not had the enough experience or been in enough situations to make those decisions, then it can become difficult, I think, for people.
Really good advice. And because I get a lot of people from Black and Asian backgrounds with lots of challenges. Have you ever had any challenge in progressing for what you might have assumed was because of your ethnicity?
I'd like to think no. I'd like to think no, but then working for the trust that I work in now, if you look at the senior leaders within that organisation, within the service lines, there's a lot more diversity than my previous trust. So, and it was only actually when I moved across, because I was going for positions in my previous trust and wasn't getting it. And I know I don't perform the greatest at interviews. So I never even, it was actually somebody that mentioned maybe it's to do with your ethnicity. And at that time I was like, no, don't be silly, because it's never been a problem before. But then when you move to a different trust and I see so much diversity in senior positions compared to a previous trust, and it does make you wonder. But I don't think personally
you can't and say actually, and I know what you mean. That I think you and I have been for similar jobs as well, where we haven't got it. And to be honest, like you say, I've put it down to how I performed at the interview rather than thinking it's because of my ethnicity. But that you'd like to, I guess, impart onto colleagues. And because I forgot to ask, and what is your current banding? Because the last time I spoke to you, well, like an B.
AA currently, because I've gone for clinical post, and obviously at that point I didn't want. So the higher up you go, obviously the more managerial. There's less clinical posts the higher up you go. And this was actually this post we'd got funding for prior to me leaving my old post, and they just weren't able to recruit into it. And it just seemed like such a shame for this post, because there isn't, especially in the community, there really isn't for nurses any clinical senior pathways. From 7 up, it all becomes managerial. And I just didn't want this post to go, because nobody was in it. So I'm hoping that we will have more band 8A ADHD sort of, or even nurse specialist posts. And I think actually within our trust and within CAMHS community there are. So we've now got risk management nurses in the community that are band 7 and band 8A, that we've got self-harm lead nurse that's an 8A. So we do actually have, we're starting to have more clinical senior posts as nursing, which is quite exciting actually.
It is very, very exciting.
Trust South West London St George's, please do.
Little plug there. And because people are always interesting, but also I don't think we talk enough about this as nurses, and later on I'd like to look at how we budget. But in terms of your salary spec, what does an 8A in the community make? Ballpoint figures.
God, I don't even know. I had to look at my piece.
Oh my God, Karren, like, how do you not look at your pay?
I think it's like from 40, so 48 to 53.
Okay.
I think we're about, so 53 top 8A banding is there. And I was, because of my 8B experience, I was fortunate enough to get the top banding out of this role. They've also revised the pay scales and everything, and the pay points. So that was the only thing that confused me when I came back. And then obviously the 8B, there's a bit more of a substantial jump. And I think with the new pay scales, 8A and the 8B don't cross.
No, they don't. Yeah, they've got a spacing between it, because before, you know, people would go, why would I go for a higher band when I make more money than my team leader?
So that's a good thing. But so I think top is about 53, and then I think if you're an 8B, I think you then start at like 55, 56 or something. So there's a little space in between.
Great. Well, thank you. So the other thing is, I know you have a YouTube channel as well.
Well, actually, yeah, because I was going to revive it. I just wasn't sure what I was going to do for it. So there is one called Dickson's Addictions. So my own YouTube channel, where years ago I used to blog about fashion and food and fitness. So they were my 3 loves, and they are still my 3 loves. But I think I just lost. I got pregnant and then baby, and then it's just time. Now I've got 2, and it's just even less time to do it. I am going to revive it actually. And then there's one that I do with my partner called Weights and Dates, which is we're going to revive as well. But that used to be fitness and sort of relationship related. But I think we're going to revive it and do family life and fitness still, I suppose. Yes.
Cool. So I'll put that in the link below. And last question, just because that you brought it up, is it challenging being a mom of 2 and going back into, you know, what sounds like quite a full-on but really important role? How do you balance that?
Yes, it is challenging. So at the moment, I'm only doing 4 days a week.
But so that means just for people on, you know, normally people would work 5 days a week, but you can apply for flexible working. I'm assuming that's what you've done. Yeah. Cool.
So I balance by that, having the 1 day, though I think I'll be going back to full-time soon. I think I tend to make sure that evenings that I try and cut off when I get home, or when the kids are home. So I may work past 5, but once from home. But then once that I'm home, then the laptop's sort of turned off, just so I've got time with them, because that's what I think I found that's why I decided to leave the NHS for a little while, was just that the workload as a clinical manager was so much that it was seeping into my family time. It becomes an everyday job rather than your 9 to 5 job. So it's very difficult to balance, but I think because I'm more conscious of it now, I make a conscious decision not to do certain things, or I may look on my phone for emails and things, but it's usually sort of just when I get a spare minute or when they're in bed and things.
Yeah, so there's balance and boundaries, so that's really good.
Yes.
Cool. Great. Well, thank you so much, Karren, for your time today. There's so much that you've, packed in to the last 30 minutes. I will end
Thanks for having me. And I love love all the stuff that you put out. I think it's really, really useful.
And I wish, can you imagine if we had this information when we started?
I know. I know, it would really have helped, I think, rather than kind of just ploughing through blindly in our career.
I know.